We'll basically be discussing about procedural management of acne. So, what are the risk factors for acne scarring? So, people generally of adolescent age group get acne, but not necessarily. Even the adults can get acne, and that is a separate topic why you can have adult acne. So, in general, the most common age for acne is the adolescent age. After acne, scarring is a sequelae. So, what are the risk factors for acne scarring? Basically, anybody who is having severe inflammatory acne, if a lot of time has elapsed before you go for the treatment, if somebody is manipulating the lesions too much, which is also called as acne excoriae, then when there is a family history of scarring, more involvement of trunk, and frequent relapses. So, I'll just use the pointer, that will be easier. So we have three types of acne scars. You have macular scars. You have macular scars where there is no change in texture of the skin. Then you have depressed scars where there is depression in the skin from the scarring, and elevated scars where there is elevation. So in depressed and elevated scars, there's a change in texture, and macular scars, there's no change in texture. So macular scars can be erythematous or hyperpigmented, and the ones which are depressed can be ice pick scars, box scars, rolling scars, linear, lipoatrophic. The ones which are elevated can be hypertrophic, keloidal, papillar, bridging scars, and sinus tracts. So macular scars can be erythematous or hyperpigmented. So erythematous means these are seen following resolution of inflammatory acne lesions which appear erythematous in appearance, and hyperpigmented which are appearing hyperpigmented due to post-inflammatory hyperpigmentation. So these are erythematous macules, macular scars, and these are hyperpigmented macular scars. Then ice pick scars are the ones which are V-shaped basically. So they are narrow in diameter, deep, sharply marginated epithelial tracts that extend vertically to the deep dermis or subcutaneous tissue. Opening is usually wide, and there is a deep apex which is pointed in a V shape. So these are ice pick scars that you can see. Rolling scars are poorly demarcated depressions of the skin. So they appear like this as a rolling pattern. If I can use a pen, so they would be like this. So that is how a rolling scar appears. So they occur from dermal tethering of the normal appearing skin and are usually wider than 4 to 5 mm, right? Then you have box scars or U-shaped scars. So these are like this, U-shaped scars, uniform round or oval scars with well established vertical edges that reach a depth corresponding to the superficial or deep dermis and are usually wider at the surface. They can be shallow, they can be deep. Okay, so these are the shallow box scars and these are the deep box scars. Then you have linear ones, which are linear atrophic lines that are commonly either hypopigmented with relatively normal skin. They may be narrow linear scars or they may be broad linear scars. So narrow ones are thin lines connecting each other, and broad ones are wide linear dermal depressions. Lipoatrophic scars are seen following resolution of the cystic acne, and they are more common in males with a thin aesthetic appearance, and they give a knot appearance to the face. So this you can see is a lipoatrophic scar. Then you have hypertrophic scars. So this you can see is a hypertrophic scar, which is elevated, dome-shaped, fibrotic scars, which can be skin-colored or hyperpigmented, seen frequently in the mandibular area of the face and the back. More common in males and in darker skin type, remain localized and do not extend beyond the surface of the acne lesions. And then we have the keloidal scars. So they extend beyond the original acne lesions. That is how you differentiate them from the hypertrophic scars. They have irregular borders, often symptomatic, and they can cause itching or pain, more often in males on the back, shoulder, and chest. Then you have papillar scars. So what are papillar scars? They appear as raised, hypopigmented, and papillar lesions, most commonly on the back, chin, and nose, and they occur due to destruction of the perifollicular dermis. These are basically outpouchings of epidermis due to loss of support of the underlying dermis. Then you have bridging scars, which are seen as bridges. So they're seen as channels which are joined together by epithelial tracts overlying normal or atrophic skin. They often contain foul-smelling products of sebum and cause great distress to the patient. So now we'll see the management of each of these one by one. First of all is the keloidal and hypertrophic scars. So the treatment options include silicone gel sheets or elastomers, The important thing about these is that they should be in contact with the hypertrophic scar for at least 12 to 24 hours per day for 6 to 12 months. So they can be removed for routine hygiene and for temporary when temporary adverse effects arise, but they should be in contact for the longer duration. So this is how a silicone gel sheet is. Response is good but requires a long time. Then we have intralesional corticosteroid injections which can be given, which have anti-fibrotic and anti-inflammatory action. We have 5-fluorouracil injections. Right, these are the treatment options. Other options include bleomycin intralesional injections, then surgical excision, which can be combined with ILS intralesional steroid injection or punch excision with postoperative laser resurfacing, and then cryosurgery can also be done for the younger ones, which are newer appearing, which seem to respond better than the older ones. Then we have laser. So laser options include 585 nanometer pulse dye laser. Other option is the 1064 nanometer, but this one is more effective. So the best results and least side effects are obtained on the Fitzpatrick skin type 1 or 2. So in our skin type, there is more hyperpigmentation that occurs with laser. So it's not a very preferred option for our skin type. Then a biologically effective dose of 30 to 40 gray post-surgical excision radiotherapy can be given in keloids and has been used to reduce recurrences. This was a study where they compared NdArg and PDL, how there's response to NdArg and PDL both, and they found that both of them had good response in this patient. It was like a split phase study. So moving to the newer treatment options, one of them is interferon injections, which basically cause a decrease in synthesis of collagen type 1 and 3 by fibroblast and increase in collagenase activity. Adverse effects include flu-like symptoms and pain at the injection site. Other important treatment options include onion extract or heparin gel, which basically possesses fibroblast inhibiting properties and has and basically it reduces the fibroproliferative activity and the production of the extracellular matrix. Heparin also plays an important role as it interacts with collagen molecules. Now we move to the treatment options for the atrophic scars. So we have three types of treatment options. We have the aesthetic approach, surgical approach, and laser resurfacing. So usually when we treat acne scars, it's not just one modality that we go for. Usually a combination approach is more often than not required. So the aesthetic approach includes chemical peels, microdermabrasion, dermal fillers. The surgical approach includes punch techniques, subcision, dermal grafting, fat transfer, basically the cross technique with TCA, microneedling, dermabrasion, scar revision, and cryoslash. Laser resurfacing includes ablative, non-ablating, and fractional lasers. So chemical peels can be either superficial or medium depth or deep peels. The superficial peels are basically used for macular and mild atrophic scars. Examples include salicylic acid 20 to 30%, mandelic acid 40 to 50%. Medium depth peels include glycolic acid 70%, 35 to 50% TCA, not to be repeated before 6 months, which is important. And deep peels include phenol 88%, TCA more than 50%, not to be repeated before 1 year. And these can be combined with subcision or sequential chemical peels can be done. Coming to the microneedling process, it is done with the help of either dermaroller or dermapen. Dermaroller is a handheld device, which is a drum-shaped roller, which is studded with 192 fine microneedles, which are 0.1 mm diameter, present in 8 rows. And the needle length ranges from 0.5 to 2 mm. 1.5 is used commonly in acne scar surgery, and 2 mm is used for deep atrophic scars. This is rolled with needling tool basically 4 times in different directions. So either first you go horizontal, then vertical, then diagonally right and diagonally left. And then you have a dermapen, which is basically needle cartridges attached to a motoring device. So you have it has a battery, and it can you can put on the battery. So it will automatically be on, and the manual pressure doesn't have to be done. It has a to and from movement inducing pricks. Then we come to subcision, which is basically the subcutaneous incision-less surgery. It acts by releasing the subcutaneous fibrotic strands that pull down the overlying tissue. Okay, so this is how subcision is done. We commonly use the no-car needle, and we go in different directions while inserting through the scar. Then there are certain modifications which improve the process, such as you can bend the needle here. Using forceps, you can blend this needle and then you can put it so that prevents the needle from going very further deep and gives a better result. And a further modification can also be done by mounting it on a syringe like this for a better grip. Then we have punch techniques. Punch techniques include punch excision, punch flotation or punch elevation, punch replacement grafting, and elliptical excision. So punch elevation is basically done for depressed small scars which are less than 4 millimeter in size, which have normal surface texture. It's also done for ice pick and deep box scars, right? Punch excision and suturing is done for depressed scars which are more than 4 millimeter with abnormal surface texture and deep box scars. Punch excision and grafting is done for depressed scars which have abnormal surface texture less than 4 millimeter in diameter, can be done for ice pick scars, deep box scars, hypertrophic and keloidal scars not responding to ILS. And elliptical excision is basically for large contiguous areas of scarring which are irregularly shaped, bridging scars, and where there is skin laxity. So let's look at the cross technique. Cross technique basically uses high strength TCA focally on the atrophic acne scars to induce collagenization and cause cosmetic improvement. It's the best treatment for ice pick scars. Since these scars are deep, destruction of the floor and wall of the pit occurs because you're using this toothpick and it goes deep into the scar. So it helps in destroying the floor and the walls of the pit, followed by dermal remodeling, leading to gradual improvement. So this is how we do TCA cross technique. Then we come to microdermabrasion, which is an easy technique done safely in dark skin and has low cost basically for the treatment of superficial acne scars. It is not effective in deeper scars. And basically important thing is that you must stretch the skin well when you do it. Then only you would get a good result. And you must achieve a vacuum to aspirate the epidermal debris and use crystals. So it is repeated weekly until the desired result is obtained. Then we come to fillers. This is one of the newer modality that is being used, but they have a temporary result. So you can use hyaluronic acid fillers, and you can also use a fat transfer technique, which is a more permanent technique. So fillers work by fibroplasia, like polylactic acid, calcium hydroxyapatite, hyaluronic acid. So these are the newer fillers. And previously what we have been using is the hyaluronic acid filler. So they are temporary. The important thing is that, and they have a higher cost. So if somebody has, supposing a wedding in 6 months and wants a quick treatment, then you can go for fillers. If the scar is fitting the where you can use, if the scar must be such that you can give fillers in that. So you can go for fillers in that. And MNRF, microneedling radiofrequency technique, is effective in reducing both atrophic acne scars and open scars. So here you use radiofrequency energy to disrupt the dermal fibrotic strands and trigger collagen remodeling. So you create basically a pyramidal injury zone, unlike the conical thermal damage zone induced by ablative lasers, and greater depth of penetration of the microneedles as compared to the fractional lasers is seen. The insulated microneedles coagulate only the deeper part, and the uninsulated cause coagulation along the full length. And you usually require 4 to 6 sessions for optimal result. Fat grafting, fillers are short-lived and expensive, so you can also do fat grafting, which has the advantage of supplying adipose-derived fat stem cells and has an important role in the regeneration of collagen. Previously, boluses of fat were injected, like the macrofat and microfat, but now we are using nanofat, which is the newer technique. So recent technique is to use the finer components, nanofat. So advantage is it is autologous, easy to obtain, minimal donor site morbidity, large amounts can be harvested, easily contoured, feels natural, and has regenerative potential. Coming to PRP, PRP again is like a natural filler. So it is basically consists of the patient's plasma that is enriched with a high concentration of platelets. It has many advantages. So one of them is that it corrects the atrophic scarring through the release of growth factors from the alpha granules. Another thing is it generates hyaluronic acid, which draws water into the matrix, causing it to swell, creating volume and skin turgor. It promotes cell proliferation, extracellular matrix formation, thereby modulating the diameter of the collagen fiber, improving the atrophic scars. PRP has been studied mostly as an adjunctive therapy to other treatment modalities like microneedling and fractional ablative laser. Lasers for acne scars can be rolling scars and superficial box scars, basically which respond best to the laser resurfacing treatment. Pitted scars and deep box scars respond less satisfactorily. Lasers used for acne scars include ablative and non-ablative lasers. Ablative lasers cause ablation of the epidermis and part of the dermis, with resultant collagen deposition as part of the healing process. So ablative lasers include CO2 laser and erbium YAG laser. CO2 laser depth of ablation is about 20 to 60 micrometer, and additionally there is a thermal injury extending up to another 20 to 40 micrometer around the vaporization zone. In erbium YAG laser, there is a depth of ablation of 10 to 20 micrometers, and surrounding thermal damage does not exceed 15 micrometers. Ablative lasers are the most effective in the treatment of post-acne scars. Side effects are there's prolonged erythema, there's prolonged exfoliation, post-treatment hyper and hypopigmentation, prolonged downtime, and risk of scarring and secondary infections. So CO2 laser is thought to be a more effective laser, as you saw that it achieves a greater depth, of ablation. But the important thing as compared to this, with erbium lag laser, there's less risk of side effects. So CO2 laser, though more effective, has higher risk of side effects. Advantage is that it has greater depth of ablation. Erbium lag laser is now more commonly used and has lesser risk of side effects. Now we come to non-ablative laser. It causes induction of controlled injury to the dermal collagen without any damage to the epidermis, leads to a healing response with dermal collagen remodeling, a tightening effect on the skin with a resultant improvement in the appearance of acne scars is seen. It requires less downtime, but efficacy of these lasers is far less compared with the ablative lasers. So they can be infrared lasers, which include the 1450 nanometer diode laser, 1064 nanometer Q-switched Nd:YAG laser, 1320 nanometer Nd:YAG laser, and 1540 nanometer erbium glass laser. Then we have the visible light lasers, which include the IPL, PDL, light emitting diodes, and broadband light sources. Among them, infrared light lasers are the ones that have been used and studied most commonly. Non-ablative lasers provide a modest improvement, not very commonly used in acne scar management, and treatment comprises of multiple sessions at 3 to 4 weeks. Then we have the fractional lasers, which are now more commonly used, as all of you would be knowing. So they minimize the chances of any serious adverse effects to the skin and create a fine balance between the undesirable side effects and the limited efficacy of the non-ablative lasers. So in the non-ablative fractional lasers, use wavelength of 1410 to 1550 nanometer and cause non-ablative columns of dermal and epidermal injury with skip areas. And so they basically cause damage in columns and their skip areas in between. Examples include 1550 nanometer erbium dope fiber laser known as Fraxel laser. And ablative fractional lasers are designed to deliver best of both worlds. This is the one which is now most commonly being used by applying ablative laser technology in a fractional pattern. So this is the one which gives the best results and is the one which is most commonly being used nowadays. So provides the efficacy of ablative laser with lesser side effects. So fractional CO2 lasers are the ones that we most commonly use. Level of scar improvement achieved with these lasers is far better than the non-ablative lasers, and also the lesser side effects than the ablative lasers. So ablative fractional lasers are the ones which are the more commonly used modality. Now we will see the management of each type of scar one by one, because we have seen each individual modality. Now management of each type of scar. So first thing that we will see is the macular scars. How do you manage the macular scars? So if you can either have persistent erythematous scars, you can have persistent hyperpigmented scars. If the persistent erythematous scars are there, you can go for chemical peels, superficial chemical peels, and alongside you can go for topical treatment with sunscreens, topical anti-inflammatory agents, salicylic acid, adapalene. If response is inadequate, it can be combined with IPL or PDL laser. Persistent hyperpigmented scars respond to chemical peels with Q-switched Nd:YAG laser, and fractional CO2 laser combined with chemical peels also give good results. Then what's new? What is new is that there's been an article published on the efficacy of tazarotene cream that has been found to improve macular acne scars as comparable to the adapalene gel. So that is one thing that is now being used. And now topical tacrolimus is also one thing that is being used for acne-related macular erythema to prevent atrophic scarring. This was published in JAD recently. Then management of ice-pick scars. Successful treatment of ice-pick scars requires destruction of deep epithelial tract and collagenization of underlying atrophic dermis. So the techniques which we use are basically the cross technique, which I told you in detail, subcision, mini punch elevation or grafting, microneedling, and fractional resurfacing. So best approach is a combination of cross and subcision followed by either microneedling or fractional laser resurfacing. Do not use fillers initially as ice pick scars may become more noticeable. Management of rolling scars, best treatment is a combination of subcision that breaks down tethered dermal bands, followed by either filler or fat transfer that raises the scar and improves the appearance. Wherever instant results are required, you go for fillers, and subcision combined with microneedling is the cheaper alternate. Laser resurfacing with fractional CO2 or erbium YAG laser combined with subcision is another good method. For box scars, basically, they should not be treated with cross technique, very important, as cross technique will worsen and cause it to become more prominent. So, what should you do? For shallow scars, go for subcision and fillers or autologous fat transfer after subcision. Other options are microneedling followed by resurfacing either by spot dermabrasion, spot microdermabrasion, or ablative fractional laser or fractional radiofrequency. Subcision combined with microneedling derma roller or derma stamping is a useful minimally invasive technique, particularly if lasers are not available. For deeper scars, the techniques include subcision, punch elevation, punch excision, and suturing or grafting, followed by resurfacing. Management of papular scars, very important. On stretching the skin, the papular scars disappear, whereas the hypertrophic scars remain elevated. So if you're having a doubt whether it is a papular scar or a hypertrophic scar, this is how you would know. So the technique for this is intralesional radiofrequency with an insulated wire electrode. Other technique is non-ablative fractional erbium glass lasers and MNRF. So this is how intralesional radiofrequency is done. You take a blue cannula basically. IV 22 gauge blue cannula, and small window is created where you're applying the radiofrequency current to destroy the papular scar. Then we come to management of bridging scar. The best method is to excise the tract, evacuate the contents, and completely excise the scar tissue. This is followed by suturing along the relaxed skin tension lines. For linear and lipoatrophic scars, for narrow scars, you go for subcision followed by non-ablative laser resurfacing. Alternate is percutaneous collagen induction by microneedling. However, make sure to stretch the skin adequately and repeat the procedure every 2 to 4 weeks until an optimal response is obtained. Cross technique is useful in hypopigmented linear scars. For broad linear scars with a narrow normal epidermis, go for subcision, followed by fillers or autologous fat transfer. For broad linear scars with atrophic epidermis, it is better to excise these scars along the relaxed skin tension lines. For deep lipoatrophic scars, it's the fat grafting or volumizing fillers, which is the best treatment option. So that's about procedural management of acne. If any questions, you can reach to me on my email ID.